Good morning, dear patient, dear colleague, dear friend. Today we will have the next lecture. The next lecture will be in the same series, will focus on nerve lesion after mesh implantation for any prolapse. During the last lecture, I was talking about mesh implantation for sacropexy. Today, I will have a talk. I will have a lecture on groin pain after inguinal hernia repair. That is really a situation that affects even much more men than women, because the incidence of inguinal hernia is much higher in men than in women. But the principle of the lesion of a nerve because of mesh implantation of surgery is in both sexes exactly the same. So, groin pain after inguinal hernia repair, and you see there are complications of herniorrhaphy and hernioplasty. There are two different kind of procedure. Both procedure, the aim of both procedure is to treat the inguinal hernia, of course. But the herniorrhaphy is using your own tissue. It's a tissue repair. Usually, we are using an open surgery and groin open surgery. And from the beginning, it's very important to understand that in this procedure, we are above what we call the abdominal fascia. So if you see the abdominal wall, you have the skin, you have fat tissue, then you have fascia, then you have muscle, then we have what we call peritoneum, and then we are inside the abdominal cavity. And what held everything is a fascia. And when you have an inguinal hernia, a groin hernia, it's because you have a small leg in this fascia and the bowel is going through. And the aim of the herniorrhaphy is to coming from outside. You open the skin, you go down to the fascia, and then you try to find this small hole in the fascia and to close this fascia. That is exactly what we call herniorrhaphy. Now there is another procedure called hernioplasty. Hernioplasty is usually performed by laparoscopy, though we are not coming from above from the skin, we are coming from below the fascia. And most of these procedure based on the placement of a mesh. That means you take a part of mesh and you close the small hole in the fascia by using this mesh. You can do that also by open surgery, but usually it's by laparoscopy. That means if you have a lesion of nerve by this two procedure, when you underwent a herniorrhaphy, the lesion of your nerve will be more likely above the fascia. That means easy to join, to access from outside. While when you had an hernioplasty with implantation of the mesh, it's more likely below the fascia. So below the fascia, it's more difficult to have a simple minimal invasive access from above, from external. If there is something, probably you will have to use a laparoscopy. So what can happen? Postoperative groin pain is a significant complication after groin surgery. And if you take a look in the literature on Pumbet, you will find it's more or less 10-12% of the patient after herniorrhaphy or hernioplasty will develop some neuropathic groin pain. But if you see some special publication like the both I have listed here, one in the Lancet is a big journal in medicine, and the BMG, you will find exactly my experience that this incidence of 10-12% is much too low. It's more so around 30 to 40% of patients after a groin surgery. So it's a quite very frequent cause for pelvic neuropathic pain. And usually it's not, the patient will become aware that something is wrong because if you got a surgery, and all surgery normally, after 2-3 weeks, you feel that the pain is decreasing over time. When you see you had a surgery like such a groin surgery and the pain don't decrease or even increase, then there is something wrong. And then in groin surgery, there are 4 questions. Before you can advise any treatment, you have really 4 questions, and you have to get a clear answer to this question. The first question is, if you develop neuropathic pain after groin surgery, there are different nerves at the groin. Which nerve has been affected by the surgery? And normally you have 4 different nerves. The iliohypogastric nerve, which is for an area above the groin. The ilioinguinal nerve, which is innervated what we call the dermatome, that means the skin area at the level of the groin. Then you have the genitofemoral nerve. It's a nerve in charge of the genital area and the groin and the internal aspect of the thigh. So when you have a lesion of the genitofemoral nerve, usually it's a groin pain with radiation down to the genital area and down to the leg, down to the knee, more or less. And then there is a fourth nerve. It's what we call the lateral cutaneofemoralis nerve. It's a nerve which innervated the external aspect of the thigh. And sometimes you have lesion of all these nerves together, and that is exactly what we call paresthesia meralgia. So the second question, after trying to find out which nerve are affected or involved in the lesion, the second is to know which kind of lesion, because it's obvious that if you have a cutting on a nerve or you have a compression on a nerve by scar tissue, the results on long term will be not the same, and the treatment, of course, is not the same. And in groin surgery, sometimes we're talking from cutting. When you open the groin, that is more in the situation in herniorrhaphy. If the surgeon makes some mistake, maybe he will induce a burning of the nerve or a cutting of the nerve, even more because these nerves are very, very small. And suppose you develop what we call a recurrence of groin hernia. That means it's not the first time you had a groin hernia, but after a procedure, you develop a new one, then it's much more difficult. You have much more scar tissue, and in a scar tissue, to find out the small nerve from less than 1 millimeter is really tricky. It's not easy. And then the risk to induce a cutting or burning or a transfixion with a stitch of the nerve or with a screw is much, much higher. Of course, when you use a mesh, you cannot use an irritation of the nerve and a lesion of the nerve. If you fix the mesh with a suture or a screw directly on the nerve, it's what we call a neurogenic lesion. You have a lesion of the nerve. Now, if you put the mesh close to the nerve, and over time, after the procedure, your body will develop scar tissue from the mesh, and this scar tissue will reach the nerve and start to tie the nerve, then it will be a secondary lesion. Recurrence of hernia may increase significantly the risk for lesion of the inguinal nerve, but also postoperative hematoma or abscess. If you have an abscess, an affection after the surgery, or you develop some postoperative bleeding with an hematoma, in both situations, your body will develop scar tissue, and this scar tissue may induce an irritation of the nerve, and that is typically what we call secondary neuropathic pain. That means you underwent your surgery, everything went well, the pain decreased after the surgery, and maybe 6 months later, or even 30 years later, you start to develop groin pain again, a burning pain, electrical shock, and then that is a tricky point. If you develop this pain 30 years later, nobody probably will come on the idea to think, oh, it may be due to scar tissue, due to the groin surgery 30 years later. 30 years before. And then there is a procedure, general surgeon likes this procedure usually, is what we call triple neurectomy. That means triple neurectomy, when patient develop an inguinal pain, it could be the genitofemoral nerve, it could be the ilioinguinal nerve, it could be the iliohypogastric nerve. So if pain, the nerve brings the pain information to the brain, one technique, cut simply all 3 nerves. So then you will not miss a nerve. You're sure that the information. If you cut all three nerves, you will block the information. So idea is nice. If you cut the nerve, the information will not reach the brain and you will not have pain anymore. But from the neurosurgical point of view or neuropelveological point of view, I mentioned that several times in previous lecture, never cut a nerve. Never cut a nerve because then, like after leg amputation, you have the high risk to develop stump pain. Stump pains, I mean, when you touch the groin, you will develop burning pain, excruciating burning pain. And secondly, you have a high risk to develop phantom pain. And this risk is more or less by 80%. It could happen a few weeks, few months after the procedure. It can happen years after. And phantom pain, we know that from leg amputations, phantom pain is a topic very, very difficult to deal with. So better to never cut a nerve. So here you have the secondary mesh-related complication, exactly what I mentioned. Due to a secondary developed scar tissue, when you bring a foreign tissue like a mesh in the body or a suture, the body will induce a local reaction, and the local reaction, an inflammation, will always end up in a scar tissue. And this scar tissue over time can start to press on the nerve and induce such kind of pain. And what I mentioned before, hematoma, abscess, are also cause. Now, the first question, which nerve? Second, which kind of lesion? Primary or secondary? Third question, the diagnosis. And it's incredible because the diagnosis is very, very often, we are very often missing the diagnosis. And when patient underwent a surgery, even more in secondary lesion, when the patient start to develop the pain months or years later, then some colleague will say maybe you have an infection, an inflammation of the bone, that you, what you call symphysitis, or maybe you have an intolerance of the mesh of the tissue, so let's perform the next procedure, or it's a psychosomatic issue, or it's simply, and the main answer is normal after such kind of surgery. So it's not normal when the pain is becoming excruciating, is increasing. When you are more than a pain level, more than 5 on a scale from 0 to 10, something is wrong. And when you see that the pain increase when the weather is changing, or when you are sitting for a while, or when you try to ride a bicycle or to jog, all these situations will induce a further irritation of the groin nerve, and then the pain will increase. Then you need a specialized neuropelveological evaluation. That means a neurological evaluation with the main answer, as I said before, it's a neurogenic or non-neurogenic lesion. Neurogenic, that means you have a cutting of a nerve, a damage of the nerve. Non-neurogenic is an entrapment, an irritation of the nerve by scar tissue. Treatment is not the same. And what I mentioned, primary or secondary lesion. But you remember at the beginning of my lecture, I mentioned that the nerve are coming from behind the kidney, are running within the abdominal cavity, are passing through the pelvic, the abdominal wall in the groin area below the fascia, are passing through the fascia, and then are running above the fascia. And that will be the next very important question. Do you have a lesion or an irritation of the nerve below or above the fascia? So more or less very superficially below the skin, or maybe inside your pelvic cavity. And that make a big difference because we have treatment option. And always you have to make the choice first for non-surgical option. So if you have a lesion, neurogenic or non-neurogenic, of the nerve above the fascia, below the skin, the treatment of choice is botulinum toxin. Of course, you can use painkiller. Of course, osteopathy is really a great option. But when all these options fail, or you have an intolerance to the painkillers. You have too much side effects. Then you have to block the nerve. And when you are above the fascia, you can't block the nerve. And the only way to block a nerve for several months is Botox. But if your lesion is below the fascia, then you cannot use Botox. You cannot inject Botox within the pelvic cavity. You don't know what you will do with this Botox. And that is the picture you see on the left. It was a patient after an hernioplasty. And you see very well here a nerve that was a nerve genitofemoral. And you see how the mesh here is tying the nerve. Because of the neuropelveological examination, I was aware that it was not a neurogenic lesion. So the key was to release the nerve. And it's exactly what I did. I released the nerve by cutting the mesh. But as I said in the sacropexy, the aim of the procedure is not to remove the mesh. If you remove the mesh, that is really not an easy surgery. You will have a high risk to induce a lesion of the nerve. And in any case, you have a very, very high risk to have a recurrence of the groin hernia. And we don't want to induce a recurrence of the hernia because we wanted to release the nerve. So you release the nerve, but you don't remove the mesh. Now, if you are aware that it was a patient suffering from a neurogenic lesion and with a specialized neuropelveological examination, you can make the diagnosis, make the difference between cutting a nerve or irritation of the nerve. So when you have a cutting of a nerve, it makes no difference if you perform a laparoscopy and you say hello to the nerve. When you are below the fascia, you cannot use Botox. So then you have only one option, is to use neuromodulation. Neuromodulation is an option to treat inguinal pain. You can use neuromodulation below the skin, but I prefer to use Botox. If you have a lesion, a cutting of the nerve within the pelvic cavity, then you have to use the lion procedure. That means you do a laparoscopy, you identify the nerve like I did on this picture, and then you bring selectively a stimulation lead electrode to the nerve, or maybe if you're not sure if it is the ilioinguinal, the iliogastric, or the genitofemoral nerve, then you can simply bring a multipolar electrode parallelly to these three nerves, mean with one pacemaker and one lead electrode, you will achieve neuromodulation of all three nerves together. You will not change anything to the lesion of the nerve, but you will try to cover the information of pain that reaches the brain by bringing a nice feeling of electricity on the nerve. So the prognosis, most of the patient, because a lot of patients are getting the procedure coming from above, will be able to be treated with Botox. So once again, if you have to make the choice between Botox and surgery, always try Botox, even if you're not sure, even more because sometimes patients have lesions both above and below the fascia. And that show even more the importance of the neuropelveologic diagnosis. So in case of the issue is above the fascia, the treatment of choice is a Botox. If the issue is below the fascia without damage of the nerve, the treatment of choice is a laparoscopic nerve release, but without removal of the mesh. And in very, very few cases, when the patient is affected by the damage of the nerve within the pelvic cavity below the fascia, then you have to achieve the lion procedure. And to give you a little bit a proportion, Botox, I'm doing more or less Botox for groin pain, more or less 2-3 patients per week. Laparoscopic neurolysis, maybe 2-3 per month. And lion procedure, probably I perform 3-4 cases over the last 10 years. So the lion procedure in the most case, really not the first treatment of choice. Botox, nerve release, and then after everything failed, then you have to think maybe about the Lion procedure. There is another kind of treatment, is the spinal cord procedure. That is really the last option. So you bring a lead electrode in the spinal cord. This electrode is connected to a pacemaker, and then you try to block the information of the pain, not at the level of the injured nerve, but at the level of the spinal cord. So, final message to you, to patient. Chronic groin pain after mesh repair or after classical repair without mesh is real, is much more frequent than we suppose, but is treatable. You can do something. And the key before you make any treatment is to have the right neuropelveological diagnosis of your situation. The treatment have to be individualized, and that is the key. If you have the wrong diagnosis, even if you do your Botox or neurolysis, you will have the wrong results. The treatment is directly depending from the diagnosis, which is the key. And the diagnosis of a groin pain after mesh surgery is a neuropelveological consultation for more or less 1 year, 1 hour, 1.5 hours. You cannot deal with such kind of pathology in a consultation for 50 minutes. No way. At least I cannot. So there are, once again, 3 options: Botox, neurolysis, and Lion procedure, but just in neurogenics, that means nerve damage, nerve cutting, and below the fascia. And I think I'm at the end of this lecture. I thank you very much for your attention. So it was the second lecture of the series, pelvic nerve complication after mesh surgery. The next one will be for a prolapse in women with a TUT, TVT procedure, and vaginal prolapse surgery. I wish you all the best. Keep healthy, and see you maybe for the next lecture. Thank you very much for your attention. Big hug.